Hello and welcome to SciLux, the podcast where we talk about scientific developments and technological changes in Luxembourg, as usual, powered by Research Luxembourg and straight from the studios of RTL City. And our guest today is Professor Markus Ollert, who is the director of the Department of Infection and Immunity at the Luxembourg Institute of Health, where he is leading basic and translational research with a focus on immune-related disorders. He has long-term expertise in the field of allergy and dermatology and also holds a position of full professor and faculty member at Odense University Hospital of the University of Southern Denmark. Among numerous achievements and activities, we can mention the fact that he initiated the Task Force on Molecular Allergology within the European Academy of Allergy and Clinical Immunology that published the world's first comprehensive user's guide on molecular allergology. Professor Ollert, thank you very much for coming today.
Hello, it's a pleasure to be here.
I was analyzing this introduction before we met today, and I realized there's a lot of learned words, very challenging for a radio person to read. There's always something, either the very long, abbreviations, or there's really a lot of learned words. Okay, sorry, just a side note. But anyway, thank you very much for coming. And as usual, I want to get straight into some of the terms that I mentioned in the introduction. And the first one is, probably because of my background, because I'm a translator, translational medicine. We're not talking about languages, are we?
No, of course, we also get lost in translation sometimes, but translational medicine is a term that describes our attempt to translate research in the biomedical field to humans, to patients, to healthy humans in cohorts, where we get patient data in a larger scale nowadays through novel methods that have been developed in the recent decades, and we can now really generate new research hypotheses from data that come from humans, because they are so deep and so fine-tuned that this is possible. We don't need the model systems anymore to generate novel research hypotheses in medicine. And this axis of research is called translational biomedical research, that is strictly focused on involving human beings.
What I don't understand is that before the research was not connected to medicine, because you're saying now we're translating it into patients, and what was happening before?
Well, as I tried to say before, we had model systems that helped us to somehow approximate our research questions. That means we use maybe animals in the laboratory, we use cell cultures, and then we came up with some ideas that were very restricted and very narrow. And then we created a novel hypothesis, we tested it further, we created molecules, and then we said, okay, now we are ready to do a clinical trial in humans. And as we know from the past, many clinical trials failed because we found out that the model systems that were originally used were maybe not appropriate. And now in translational medicine, it's a bit different. So we have now, after what I call a revolution in technology, we can sequence the genome, we can look at thousands of factors at the same time. This gives us so much information that we can use this information from the human beings, from the patients, to then generate the hypothesis. And this is much more precise than it was before with these model systems. And so the likelihood of success of what comes out of research nowadays through the translational medicine approach is, of course, much better and can most likely generate better solutions for what we call precision medicine, that we, fine-tune the diagnosis and the therapy for the patient needs, for each individual patient needs.
You just exactly took out my question. I was just going to ask you where the precision medicine comes into play. So that's exactly there is a synergy between those two.
Yes, absolutely. That's one of the reasons, but I would even take it one step further. I have to admit, I also many parts of my career I have spent with model systems. I have treated patients in a hospital. I was a senior physician in a German university hospital before I came here to Luxembourg, and I have been treating patients on a daily basis. But to do the research, to analyze the questions that we had from the patients, we first had to go into model systems, and then we try to translate it back to the patient situation. Nowadays, we start with the patient and we bring it to the laboratory and try then to bring it back to the patient. But the likelihood of success is higher nowadays because we already start with a set of very, very good and deep and analyzed data from patients.
That must be way more exciting for a practitioner, I would say, because otherwise it was just those two worlds and you didn't know where you were with it. Big gap.
I mean, I'm not the youngest anymore. And so if I would have a wish to start again in my career as a biomedical researcher, I would like to do this now because we have so many technologies available. So this is fascinating for me. And I feel blessed that I'm still there at that time. But I would like to be very young and do this from the beginning of my career, what is possible now.
Well, that's a good appeal to all the people who might be interested to go into that field also because it's an important part in Luxembourg research in general.
Absolutely.
But I want to get a bit more into details because we have the Department of Infection and Immunity. We'll talk about allergy in a second. But first of all, immunity. Where are we with the research? What do you do about it? What can we say? What can we do nowadays with immunity in the body?
Well, that's another fascinating story also in the field of the development of novel drugs, novel medications that we have started about 20 years ago to very precisely target, certain players of the immune system that were responsible for certain patient symptoms. And let's take a simple example. People with rheumatoid arthritis, this is the inflammation of the joints in our body, in the knee or in the elbow, in the shoulder or in the fingers. And this is a very severe disease. And people found out in the late 90s that a certain cytokine, that's a hormone of the immune system, is dysregulated. It's very high in these patients. And when you block it, and this was at that time still done in model systems, then you can reduce the disease burden of an experimental animal and of a patient. And this was basically the breakthrough of modern immunotherapy, where, in a very precise way, certain hormones of the immune system are targeted by what we call monoclonal antibodies. These are so-called biological therapies, very precise, may generate much less side effects than the former types of immune treatment that were very, very broad and caused a lot of side effects in many patients. So this was a revolution at that time, more than 20 years ago. And then from then on, many, many, many factors of the immune system that are either too high or too low or out of control in specific diseases, in inflammatory diseases of the bowel, or in rheumatoid arthritis, in multiple sclerosis, in allergic diseases like severe asthma, and many, many other diseases, also in cancer, immunotherapies now with so-called monoclonal antibodies. All this has become the new standard, so to speak. And so the manipulation of the immune system, or let's call it hacking the immune system, has been extremely successful in medicine over the last 2 decades and has brought enormous value to patients.
So it's again kind of a precision discussion then.
It is a precision discussion, correct. And but of course, we should not forget that we can in this way provide relief to many people who suffer from severe symptoms of their disease, but we cannot cure it. So that would be the next challenge now, that we might even provide cure by manipulating the immune system. A good example is not really cure, but prevention of disease through vaccination. We have now all experienced that during the COVID crisis, that we can actually very successfully prevent severe disease. So this is a concept that has been around for a long, long time. This is also what we call antigen specific. That means we are playing with the immune system, that it specifically targets something that might be dangerous for the body. And in these monoclonal antibody therapies, this is not really specific. There we rather block a factor that is important that the disease then happens, or the patient is not, freed from the disease. Like in cancer, it's actually that the immune system is not reactive enough against the tumor or against the cancer cells. So there we have to somehow take away these breaks against the eradication of the tumor through the immune response. And so we have learned all that. And as I said before, the next challenge is now to do it what we call antigen specific. That means we have to educate or re-educate the immune system that it turns away from its bad intentions, so to speak, to harm the body.
So we got very technological and advanced and all that. And I just kind of went back in memory to the times when I was a child. And my mom was always telling me, the best thing for the immunity is to be outside all day. And what about all this advice that we're given about, contact with other germs that is important when you're a child? Or, I don't know, being outside a lot and breathing fresh air and all that. Do you still do that? Or you just focus on now we can target these important parts and we don't care about this development of immunity that we talked about in the past?
Well, what you're just mentioning is becoming extremely important, not only for the research in the diseases that we are working on, but also now, within the scope of the changes through the environmental changes that we are observing right now. So having the right environmental exposure, that's how we term it.
Exactly. I couldn't find the scientific term, sorry.
Extremely important, especially for preventing allergic diseases. So this is an absolutely new concept that was developed by researchers in Germany, in Switzerland, in the US, who found out that when they looked at children that grew up in very basic farm environments in the Bavarian, the Swiss Alps, or Amish people in the US, they had much, much, much less of these modern severe diseases. And allergy is the first one that happens in the lifetime of many humans. That's why it's so easy to observe early on. After a few years, you get the result, yes, the child has asthma or not. So it's much better as what we call a readout. That means something that we can measure. And we have learned now in recent years that it's not just the bugs. It's really this environmental exposure that you put your hands in the dirt, in the ground, you touch a tree, you basically live with your environment. You're living close to your environment, and this becomes more and more important. So it's actually the lack of natural environmental exposure that drives a lot of modern diseases. At least for allergy, I can say that, but I would take it a bit further, being a bit, let's say, non-scientific here, and say, well, it's probably also causing other environmentally driven diseases that have skyrocketed in the recent decades.
You moved so nicely and smoothly into allergy. So, that's a good moment to actually ask the pub quiz question that you prefer that is related to that. And then I will have a lot of questions. So if you can ask the question and listeners remember the answer, will be only at the end of the podcast.
Dear listeners of this podcast, I really would like to know from you whether you can tell me how many people in this country, in Luxembourg, are suffering from an allergic disease.
Okay, great. You will know the answer only at the end of the podcast. Of course, you can Google it, but that would mean you can't focus on the podcast, so don't do it. Just keep listening, and the answer will be at the very end. Allergies, you mentioned that, and this is also something that is dear to my heart, and I think probably I always, imagine you in a private setting. I'm sure everybody is telling you about their problems, right? Because, you're an allergy expert. So I'm sure that the moment you meet someone new, they tell you the whole, medical history of their disease. So of course, I'm one of the people in this room that suffer from allergies, nothing serious. But of course, it's definitely, from my lay perspective, becoming more and more common. I can see friends suddenly having allergies or allergical reactions. So there must be something going on. So I'm sure you're on the quest to figure it out, because we still don't know, or we do, for certain allergies.
Well,
what's the trigger?
Don't really know the final answer yet, why it is really still increasing in most countries worldwide. I don't say how many people are suffering from it, because that will only be known to the listeners at the very end. However, it's still on the rise worldwide, and it's also not only in the what we call westernized countries like Luxembourg or here in Europe, where we have modern lifestyles since decades. It's also now on the rise in the developing world, where people get more wealthy, more affluent, have more access to, to higher quality lifestyle. We also see more urbanization as one of the reasons. And so what we see in this part of the world, in the developing world, they now are starting to suffer from these modern diseases like allergies and autoimmune diseases, but at the same time still have all this burden of infectious diseases in these countries. So that's actually what WHO, the World Health Organization, has called a double disease burden in these countries, and doctors are not trained there to actually take care of that. So that's another aspect. But why is it still increasing here, and what are maybe the reasons? Well, I mentioned already before that this, lack of exposure very early during our childhood, in the first 1,000 days of life, we are saying it's very important that you get the right signals to train your immune systems. Most likely, as you have mentioned before, it's factors that are related also to signals from bacteria, from microbes that come from the environment, that we need what we call at a very low level, at a low dosage, to train our immune response to be alert in a certain way that it does not react in this wrong way, causing an allergic disease. However, this does not explain all. And now there is a new hypothesis coming up that is currently tested worldwide, and there are a lot of data already that this might be probably one of the reasons, because we have had modern lifestyle already since the 60s here in mid-central Western Europe. And we actually have seen the start of the allergy epidemic from the 1960s on. Before 1960, there was almost nothing. So it's modern lifestyle, yes. And then we saw a steep increase to a level of maybe 10, 15%. And in recent years has been increasing further. And what has changed? Well, of course, we are spending much more time indoors, sitting, not moving enough. That's very important. And then in recent years, what came in addition was that many of us are eating highly processed food with, substances in the food that are actually not ideal for human consumption. There are substances in there that are considered safe by, the regulators, by the European Union or the FDA in the US, so they can be used for food production. And this is usually done by classical toxicology testing. That means this substance is applied to an animal. If the animal doesn't die or doesn't develop a cancer within a certain time, then it's considered safe for humans. And this is, of course, not what we are observing. All these substances do not generate any harm immediately. But what we have learned now, that some of these substances actually are at the low dosage that we are consuming them, are hurting the surfaces of our body. Can hurt the skin on exposure, but of course we are eating, so it hurts also the surfaces of our esophagus, of our stomach, of our gastrointestinal tract. And this is causing kind of a constant low-grade inflammation, kind of a pre-disease condition that you don't feel. But of course, when you then are exposed to an allergen, by inhaling it in your lungs or by eating it through your nutrition, then you're already at a stage where the immune system is expecting something foreign, something that might be harmful. And that gives then a certain signal that leads to the initiation of this, basically of what we call an expulsion reaction. The immune system, body wants to get rid of it. And this is because the immune reaction, the way we describe it in the allergic patients, is very similar to, or almost identical to, what we develop against parasites. And so the normal behavior of our immune system is to expel the parasite, to get rid of the parasite, to not let the parasite penetrate deep into our body, to keep the parasite on the surfaces of our, what we call epithelia, of our mucus, And so the same thing is actually happening with the allergic reaction. So it's an expulsion reaction and is most likely triggered by lots of substances that we are daily exposed from the environment, from the air, through the food, and also through, let's say, novel behaviors like shampoos that are liquid, or also, for instance, when you go into a restaurant and you get a nice glass of water there, they have usually this program that cleans the glass, makes it mega shiny within a few minutes. And studies have been published in recent years showing that the amount of detergent that is in the glass is higher in such a glass of water than the amount a dermatologist would put on your skin in the back when they do a skin patch test to test whether your skin is more of the irritable condition or more of the allergic condition. So something that is 10 times higher in a glass of water that we drink. I mean, imagine we are much more susceptible to barrier damage in our intestinal surfaces, on our esophagus, in our oral mucosa, compared to our skin, which is actually a solid surface. And it's a 10 times lower amount is enough to cause irritability on our skin. But this is also allowed. So we are constantly harming the surfaces of our body. And now the hypothesis is, and this is tested worldwide, that this is causing the allergy epidemic, or is one of the reasons why we have seen a skyrocketing explosion of food allergies in the last 10, 15 years. And well, of course, the hypothesis would be that it's also a driver of many other modern lifestyle diseases.
So next time I go to a restaurant, I will not complain if the glass is dirty, because that's probably better than if it's
the best
washed.
thing is you choose a seat where there is kind of a plant next by, then you take a first glass of water, give it to the plant, and then fill in the second one, and then you are at a concentration that is lower.
Is that what you do personally?
Sometimes I did it, yeah.
Okay, so that's kind of a small recommendation, of course, unofficial one, right? I understand. Okay, so we have all these factors and all these probable causes and all that. So what do we do now? What does LIH do? Where are you with the research? What are you planning to target?
Well, worldwide, the research is going in this direction, that we have to really prove this barrier hypothesis, that this is really causing disease, because then we have to give, based on research data, new recommendation to regulators and to politicians, because it will take decades until this will be put into new laws all around the world. So that's the one thing, because there was always, of course, a huge industry behind all this, a huge lobbyism, tax-paying companies, so politicians are not always eager then to immediately react. But we have to also see the fact that the chronic diseases kill people daily. And when I speak of chronic diseases, we are not only speaking about allergies, many other diseases. And so I think it should be taken serious, because it's not an immediate killing, it's a slow killing. So if you want to avoid this, we should do something. What do we do at LIH? We have been very much involved in allergy research in several groups in our department at the LIH, characterizing the allergens. It was like this molecular approach that you mentioned in the beginning, because allergy is always caused by a complex extract from nature, from pollen. This is not only one allergen. There are many factors in there, or insect venom sting from a bee or wasp. It's also a complex mixture of many things. So we needed to understand first what is actually causing the allergic reaction. So this has been done in the last 20 years. So basically we can tick this box.
So you just took the venom or whatever pollen and you just analyzed it inside out.
Cloned all the allergens by biotechnological approaches, then made them in the test tube recombinantly, and then gave all this knowledge to diagnostic industry, and they made new tests, which is called molecular allergy diagnosis tests, that complement the classical allergy tests. And in this way, you can have a really clear and precise diagnosis of every patient nowadays without any problems. Unfortunately, this is not implemented in all the countries, because the reimbursement systems for allergy are actually insufficient worldwide in most countries.
But it is implemented in Luxembourg.
It is implemented. So that's what we did in the last years. And now the next step is, of course, to understand and also contribute to this research on the barrier hypothesis. So there are some of my colleagues, Christiane Hilger, Dr. Christiane Hilger at the LIH is a group leader, has been at the LIH already for 30 years. She just recently had her anniversary here at the LIH. And so she's working on this hypothesis on the airways, that means on our respiratory system. And then we have Annette Kuhn, Dr. Annette Kuhn, and she's especially working on food allergy, children with peanut allergy, to find out what drives these reactions, how we could better diagnose that, and how we could actually prevent it and maybe even treat it in the future in a curative way. So that's what she is doing. And in my research at the LRH, my main interest is how we can actually re-educate the immune system much more efficiently not to react allergic anymore after a patient has already become allergic. So that is what we call allergen-specific immunotherapy. Many people also know it as desensitization therapy, and it's more a lay expression, but it describes it in a similar way. So where we treat a patient with low amounts first and then higher amounts of allergen over time, over 3 to 5 years, and re-educate the immune system to become tolerant to the culprit allergen.
But how do you figure it out? Because I know that in the past, it was just exactly that kind of small amount that you get systematically, and then it might work or it might not. Mm-hmm. So what is the improvement here of this process?
Of course, we have to do clinical studies, which is now for most of these therapies done. So they had to go, some of them were already on the market before, and then the European Medicines Agency requested the pharmaceutical companies to redo clinical studies for all these allergen-specific immunotherapies. So nowadays you have for all of them really highly controlled data from clinical trials. So we know that they work and they provide improvement of quality of life or even cure a certain amount of patients in a setting of an allergic disease. So this has been done, let's say, over the last 10 years. So this is a clear improvement. But of course, mechanistically, and that's why we in research are so much interested in this, we want to understand and try to understand more and more why is an immune system, as you just asked before, not reacting in the right way, and tolerance happens in immunotherapy, and why in some patients it works. And we understand more and more the factors. This becomes very molecular. But what's interesting is that these are very similar factors that also are out of sync in individuals that actually develop allergies early in life. And it's a very similar system on a immune molecular level that gets out of synchronization early in life, and you become allergic. And then when we turn it on, we now learn that these are very similar immune cells, very similar mechanisms that we have to switch back on, because the immune system has lost the ability to switch them back on by itself. And we even have some very interesting data now that's not from the LRH, that's from a group in Kiel and Berlin in Germany with some Austrian colleagues together. They found out that the cells that teach our immune response to be moderate, not to react in such a strong way to an allergen, that they are called T regulatory cells, regulatory T cells that orchestrate kind of the tolerance response of our immune system to an antigen, to an allergen, something that the immune system should not react. And for instance, if you are eating potatoes, your immune system has learned over the years that you should tolerate potatoes when you eat them in your body, and the antigens, the allergens that are in there. And this needs some education. And in those people that are allergic, especially for people with asthma and allergic rhinitis, this has been shown that these regulatory T cells, they react with the wrong components of the pollen extract. They react with something that is not important, but they don't react with the allergen. And that actually also is a study that is very important to teach us, well, it takes probably some years to re-educate these cells until they become fully active and can then provide this protection against the allergic response. And this is actually the clinical reality. It takes a minimum of 2 years, and then you need to treat at least 1 more year, 3 years, and then you can actually predict that the patient can be tolerant to an allergen or not. But what we can't do, and this is our research, we can't predict, let's say, in the first weeks or the first 2-3 months, well, this will be a successful treatment, and this might not be successful. We might have to change this to another treatment, for instance. So this factor, this prognostic biomarker, that's how we call it, we don't have yet. And this is also some of the research we are currently doing.
Which means that you try with one thing and then only after a pretty long time you figure out that this is not working.
Yes, we have, of course, in some allergies, let's say we have some earlier markers that tell us that the patient responds. And we are using these type of allergies and treatments as a model because then we have an earlier result and we can modulate our research and adapt it maybe to, change the factors. And that's what we are doing right now. And this model that we are using is an allergic disease to the stings of the insects, of bees and wasps, because this is actually we don't even know why, the most successful allergen-specific immunotherapy where we can cure more than 90% of the patients. So that's not so common in many treatments in medicine nowadays. So more than 90%, it's for sure they will be cured. And that's why this is an ideal model, because it's basically the model that in a daily routine, allows us to induce tolerance again, although the person was severely allergic, and some of these patients end up in intensive care and get severe allergic shock reactions, have to go through reanimation, and we can really cure them through this immunotherapy. So this is fascinating, and that's why it's a very interesting model that we can use to then use the results and take maybe the lessons learned to other allergies as well, and also make the treatments there more successful.
Well, I guess that's also the question, whether you can actually extrapolate and use that approach to other allergies. And I understood from what you said that it's not, you can't put them in one bag and say like allergies, okay, we have this approach, it's going to work for all of them.
No, unfortunately not. So you have to find individual and precision-based solutions, and that's actually at the heart of allergology, that's the name for the discipline, that you need to have a precision-based approach. That's why it's maybe also kind of a complicated field. And it also, of course, arrived late in medicine because allergologists were not known at the time when the classical modern medical disciplines were set up. And that's why maybe it's also not so well represented in medical faculties around the world. And that's maybe also one of the reasons why then reimbursements are not so well done as compared to other areas of medicine, because a certain lobbyism is maybe lacking here.
You said re-educating T cells. So I hope we're not going to get too technical here, but I was just wondering what actually that means. I have no idea how you work with the immune system. When you tell me an organ, okay, I understand that, intervention, surgery. And here we're talking about like medical treatment in what sense? Some drugs that you take, or you just take those T cells out, you educate them in a school, you put them back in? No, obviously I'm joking here, but what do you mean by this?
Well, you're not joking, because in some diseases this is done nowadays.
Okay.
For instance, in cancer treatment, which is, this is not that directly related to allergy, but there, the T cells of the patients are taken. They are even genetically manipulated to make them stronger, to make them more resistant, and make them more attacking against the cancer cells. So this is a standard treatment. It's called adoptive immune therapy. And this is a treatment that is now actually in the first clinical trials also extrapolated to what we call autoimmune diseases. There has been recently a very nice study published from colleagues at the University of Erlangen in Germany, where they showed for very severe autoimmune diseases called lupus erythematosus. And in this severe immune disease that is a little bit like rheumatoid arthritis, with a lot of pain in the joints of the body, but also in the muscles, and even very severe affections of the central nervous system sometimes. And they can, by taking T cells, especially regulatory T cells that I've mentioned before, the damperness of the immune response, they take them out, they manipulate them genetically, reinfuse them in the patient through an infusion, and then they were able to really improve very severely affected patients through that type of therapy. So it's possible. It's not only some future scenario we are talking about. But in allergy, we probably won't need that. We will probably never treat a severe asthma or allergic rhinitis or anaphylactic patient with a severe food allergy with this type of T-cell therapy. We can do it in a more elegant way because we know the antigens, we know the elicitors, so we can actually use these substances and provide them in the right context to the body to then educate the specific part of the immune response. And this is the T cell response is one of the specific arms that then leads to the right antibody response as the next step or as a consequence. And this is what we can do in allergy and basically reintroduce peripheral tolerance. That's the terminus technicus of the immunologists. So
peripheral tolerance.
Yes.
Okay.
So because we have what we call central tolerance, this is the tolerance that we develop, that we don't have an autoimmune response in our body. This is done in the thymus gland. When we are young, our immune system is trained there not to attack our own body. That's called central tolerance. And peripheral tolerance is the tolerance to the antigen in the periphery of our body, but also the antigens that come from the environment. And allergens are just antigens from the environment in a way. So we can use that. And if we can do that successfully with allergic responses and understand the cellular and molecular pathways, these concepts could then also apply to treat autoimmune diseases better in the future, because it's basically a very similar concept to reintroduce the tolerance in the periphery of our body, of the peripheral immune system, to tolerate certain autoantigens, which are factors of our own body that are sitting in a knee joint or in our brain or wherever. And then all of a sudden the immune cells attack this, or the antibody attack this. And we need to educate the immune system. So in a way, it's something that we really want to do in the allergic diseases, and we are already doing it, but we want to optimize that, because at the end of the day, when we think sustainable also with regard to healthcare systems, it's probably better to cure people than to treat them on a symptomatic basis for the rest of their lives.
Probably. I would say so. But let's stay still a bit with the molecular allergy, because I mentioned this user guide that you prepared. And what clicked in my mind right now is that you mentioned that a lot of practitioners or a lot of GPs don't have the knowledge. So is that user's guide actually aimed at them to give them the knowledge on treating, on helping patients with allergies?
Yeah, absolutely, because this knowledge was not there 20 years ago. So we then decided, after most of the allergens were known and were defined on a molecular basis and diagnostic products became available, that we now need to put this together in one book to really educate doctors. So it's written in a way that is not for dummies, certainly not, but
no, I confirm.
There is always an algorithm in there that, you start with a patient having this and this symptoms, and then you want to find out, is it, this cause or this cause, and which type of therapy, because, not each allergic reaction to a group of allergens requires the same therapy. Sometimes immunotherapy is possible. Sometimes it's not possible. Sometimes it's better just to have symptomatic treatment. And all this is we try to explain in this user's guide for all allergens known at that time. It was in 2016 that we first released it, but also on a global scale. So because allergens, of course, differ from, geographically around the world. And this has also been respected in this context. So there were people contributing from Latin America, from Asia, and from all over the world. Yeah.
And why is it sometimes better to treat the symptoms instead of actually targeting the allergy?
Well, because for certain allergens, and I speak of molecules in a natural extract, these molecules are not highly represented in an extract. So if you want to train the immune system to not react to something, and this is not really present in what you're using for treatment, you can treat forever, nothing will happen.
I got it this time. I got stressed when you mentioned the dummies part, because it's true. I tried to look at the user's guide a bit more in detail, but it was definitely not aimed at me, which, proves the point. So I guess this is the moment of the podcast where we go back to the beginning when you ask the question, because I think we can discuss a little bit that. And then we'll, as I promised, talk a little bit about autoimmune diseases as well. So can you please ask the question once again and then give us the answer?
Yes, I wanted to know how many people in this country, in Luxembourg, are suffering from an allergic disease. When I speak of allergic disease, I really mean allergic diseases that are caused by IgE antibodies, immunoglobulin E antibodies. So I'm not speaking about contact allergy and other non-antibody mediated allergies. I'm really speaking about IgE, immunoglobulin, antibody mediated allergies. How many people in this country?
And the answer is?
The answer is, in percentage wise, it's more than 40%. We based this at the research results have not been published yet, but the manuscript is about ready to be submitted. And we did this based on what was called a European Health Epidemiological Survey, Luxembourg, that was performed in around 2014-15. And we got all the deep questionnaire answers from the participants. It was healthy adult Luxembourgers. Maybe I should have phrased my question even a bit different. I mean, we're speaking about adult Luxembourgers, not children.
So now some of the people are saying, oh, come on, I gave the answer right. You just didn't precise.
But the numbers in children will not differ. So we speak about the same, probably a similar percentage. And so both the questionnaire answers were very clear, more than 40%. And then we did a test and it was never done in what this is called an epidemiological study. So we look at a representative part of the whole country that is representative for the whole country. So of course we have not measured all 640,000 people in this country, but we have measured a representative sample. And what we have done, we have used a test based on molecular allergens that contains more than 300 allergens. So this is the most advanced test in this field.
Definitely reimbursed in this case.
No, unfortunately not. In this case, we got a research support, of course, and we are running this at the LIH, this test. And actually some of the allergens on this test are also coming from the LIH. It's meant to really help diagnose allergy worldwide, and it does. It also is used worldwide. This test, it's a normal in vitro laboratory diagnostic test, so it's licensed in many countries, also for reimbursement in some countries. And we use this test in this epidemiological study, so we have very good data on the immune response in parallel to this questionnaire, and the data between the questionnaire and the immune response are more than 95% concordant. That means that we have a very strong overlap of the questionnaire results and the actual antibody results. And in both ways, we found more than 40%. So that's roughly, when we extrapolate this number, more than 40%, 42 to 43%, roughly 260,000 people in this country, which is an enormously high number. And we are looking back 6 years, 7 years from now. Might be higher now. We don't know. Of course, we have to continue doing research on that. And so far, except for the United Kingdom, no other country has reported such high numbers as Luxembourg. And of course, it needs to be published first, but the data are very solid.
The first question that comes to my mind is why such a high number?
Well, that's, of course, the next question that we have to ask. I mean, there are many possible reasons. We need to address this, I think, also at a certain point with the responsible persons in the Ministry of Health, in the healthcare system. Why? Might be lifestyle. Might be, of course, we know already since some years that countries with a higher quality of life, also wealthier countries and regions in the world, also wealthier families, people tend to have more allergies. So it's, let's say, from what we knew from the past, not so surprising that such a highly developed and wealthy country like Luxembourg in general has a high burden of allergic disease. But of course, on the other hand, you should ask the question, why is it not, controlled better? And we might have to look at factors like, do we have sufficient diagnostic measures in the country? Do we have enough people providing allergy service on a high quality that is of international standard with, continuous education of the allergists who are doing that? I mean, all these questions need to be asked first, and then answers need to be given, because people tend to take allergic diseases as not so serious. I mean, the term being allergic is kind of used in the lay sentence. I don't like that. And, I'm allergic to that. I think what we are looking at, of course, everybody is aware of the severity of cancer and of severe autoimmune disease or of severe disease of the nervous system. I mean, these are severe conditions and we have to take them serious. But on the other hand, when we're looking at allergic diseases, and there have many studies in the health economy sector have been done, they are causing so much loss of value in these modern societies because it's mostly affecting the young ones in the society, the children, the adolescents, the young adults who are the workers in a country, the taxpayers. And if they are out of school, out of university, their chances in their careers might be lower. Their productivity is much lower. I mean, this is people are not all of these 40% of Luxembourgers who are suffering from allergy are immediately at the risk of dying, like from a severe heart condition, but it's causing a lot of also impact on the socioeconomic system, and maybe this is something we should also keep in mind here, that this is also taking allergic diseases serious is also an investment into the future of a society.
Of course, again, looking from my perspective and around with friends, it's a lot to do with the quality of life, especially when we're talking about food allergies and severe food allergies. I mean, daily fight with everyone is having a nice meal because it's such a social thing to do, and you're missing out on it. And you have to travel with your own food or whatever else, just for food allergies and all the other possibilities. The fact that all throughout the year you need to know when the pollen is there, because then you kind of expect certain, lower quality or worse, you're just out for some time, right? So it's really definitely something that needs to be addressed. And I also need to address something else, because when you were precising the question, you mentioned the IgE, and you said this is only the IgE allergy and not something else. So we have different types of allergies still? I thought allergies are all the same.
No, unfortunately not. That's why it's a complex discipline. So they are not the same. So we are differentiating between allergies that are caused by cells only. So like contact allergy, nickel contact allergy, for instance, to metal ions, is an allergy that is only caused by cells, by so-called T cells. They're specific for this molecule, for the small molecules, and they cause usually then what we call dermatitis. It's kind of an inflammation of the skin with some scaling of the skin, and it's itching. And this is something that can also become bigger and involve also other organ systems, very rarely, not only the skin, but it's mainly the skin that is affected here. And then we have these so-called antibody-mediated, immunoglobulin E-mediated allergies, and these are allergic rhinitis, then asthma, allergic asthma. Many cases of asthma are actually allergic. Then we have urticaria is sometimes, or in many cases, also mediated through IgE antibodies. So that's kind of the itching disease when there are these wheals and bubbles on the skin that, are red and itching as well. So this can be mediated by IgE. Then the most severe is food allergy with anaphylaxis, or insect sting allergy with anaphylaxis. Anaphylaxis means allergic shock. So you are really losing your blood pressure. You are, maybe fainting. You really need reanimation treatment. There is a kind of a standby early treatment. So many patients with severe risk for anaphylaxis are advised to carry a self-injectable adrenaline auto-injector that you can put even through your trousers or through your skirt into your upper leg, and then treat yourself, or somebody who's next to you can do that for you. But you need to be trained to do this. And this can actually prevent the severe consequences of anaphylaxis, that you need to go to intensive care. It can ameliorate, it can reduce the symptoms. So that's something very important to know. And then there are also new diseases now, allergic diseases only developed in recent years. One of them is called eosinophilic esophagitis, and many people are now suffering. It's really becoming more and more, and gastroenterologists know that. It's basically an allergic reaction of the surface of our esophagus, because that's the first part that is, where we have contact to allergens that we are eating, and many people have this now. Basically, it's very similar in terms of when we look in the microscope and investigate this and would compare it with atopic dermatitis, which is the last one I should mention. Atopic dermatitis or eczema or neurodermitis, it's also sometimes called in the German-speaking area. This is a disease where also, especially in children, IgE antibodies are causing the severe reaction of the skin itching. And when we look in the microscope and compare this atopic dermatitis with eosinophilic esophagitis, it's very similar features that we find there. And then there's another disease that is also caused by IgE antibodies. It's the chronic rhinosinusitis. So that's basically an allergic disease of the sinuses that you also can treat with monoclonal antibodies nowadays very efficiently and very rapidly. No surgery anymore needed.
Okay, good to know for sure. I will tell all my friends who have allergies to listen to today's podcast for sure, and everyone else as well. I hope you found it interesting. But we still have to continue talking about diseases because I promised, and when I was preparing, I have it on my list, and that's one of the things we haven't touched upon, but you mentioned it a lot. Autoimmune diseases. What are these? Because, we talk about them, I hear them, but it's like this term that you are supposed to say, yes, I understand, but then I don't make the links.
Mm-hmm. Yes, autoimmune diseases are diseases where the body's immune response turns against the own body, against structures of the own body. And these are then so-called autoantigens. They belong to yourself. That's why it's called auto. It's autologous in your body. And this can be surface structures on cells of a certain tissue. This can be secreted factors that come out of the cells and are floating around in a tissue, like in the joints. There are autoantigens that are involved in this rheumatoid arthritis, or in multiple sclerosis. There are autoantigens that are sitting on some of the surface structures of the nerves and that get attacked by immune cells, by T cells then. So it's a specific response in most cases where either T cells become specific for such a structure or antibodies become specific for your own structures. And this is then part of the diagnostic process that you can detect these autoantibodies against autoantigens. And this helps the doctor to make the right diagnosis, to differentiate one patient from the other, one treatment that might be necessary from the other treatment. And then we have another class. I mean, and I'm speaking really now more general, and there is, of course, more and
we don't
more
have
detail,
enough time for sure.
There's another class of autoimmune diseases. I mentioned one before, like lupus. It's more what we call, it's an interferonopathie. That means that we have two axes of our immune system, the specific one, adaptive, and then the innate, the older one, which is the part of the immune system that is a bit less specific. It is specific for structures. And there are patients who have a lack of let's say, coordination, this type of immune response, and their levels of these inflammatory cytokines, hormones of the immune system that we normally use to defend us against viruses, they're always a bit too high. And this causes a chronic level of inflammation more or less systemically in the body. And this is, for instance, in such a disease, the reason why they get again and again flare-ups in the skin, are very sensitive to sun, have massive muscle ache or joint aches. Yes, so these are more or less in a nutshell the types of diseases. And as said, there are many of them: multiple sclerosis, rheumatoid arthritis, just to name two of them, where we have antigen specificity, and then these interferonopathies like lupus erythematosus.
Okay, this was very interesting. Really, I definitely am itching a little bit. I don't know, when we talk about allergies, I always get an itch, it's kind of like a reaction about all these things you can get. But anyway, thank you very much, Professor Ollert, for today, for coming and discussing all this. This was, as I said, very interesting.
Yes, thanks for the invitation. Really enjoyed it. And hopefully the listeners will do as well.
Yeah, definitely follow Professor on everything that is happening with LIH and allergy, because as we discussed, it's an important subject and we definitely need to address it. Thank you very much.
Thank you.
This is it for today. As usual, don't forget to subscribe, to follow us, to check what we're writing about on Twitter, LinkedIn, Instagram. That will not be writing, but posting different things. And just write to us if you have some suggestions for guests or just comments about the episode. Remember, this was Silax. And my name is Hanna Siemaszko.